Hello. Good afternoon. We will be starting our post-lunch session now. Focus on the rectum. I would like to introduce our distinguished panelists. Dr. Vasantha Vijayanayaka, Consultant Colorectal Surgeon, the Faculty of Medicine, University of Kotharawa Defence University. Professor Jayantha Balavardhana, Professor in Oncology, Faculty of Medicine, Kotharawa Defence University. Dr. Kesara Ranatunga, Consultant Colorectal Surgeon, Faculty of Medicine, University of Peradeniya. Professor Pramod Chandrasinghe, Consultant Colorectal Surgeon, Faculty of Medicine, University of Kelaniya. Dr. Lakmali Paranahewa, Consultant Interventional Radiologist at Asari Hospitals.
Yeah, good afternoon. For the post-lunch session, we will start with Dr. Padmini Hewavitarana, Consultant Radiologist, our senior consultant from Royal Perth Hospital, Western Australia. She'll be talking about staging of rectal cancer with PET and MRI scan.
Very good afternoon to all of you from beautiful Perth, Western Australia. Thanks for the organizers for having me today. My talk is on role of MR and FDG PET in rectal cancer management. Colorectal cancer is the third most common malignancy worldwide, and 1/3 of them are rectal cancers. And early rectal cancer patients can have a direct surgery, whereas advanced cancer patients will need neoadjuvant therapy prior to it. Treatment response varies among rectal cancer patients. Some patients show complete regression, whereas some tumors may even show progression during the treatment. It's also widely known that rate of local recurrence is variable. So with this context, precise risk stratification is necessary for better per-patient treatment plan. Therefore, radiologically defined clinical stage is very critical to determine the optimal treatment plan for each patient. Management of rectal cancer is an evolving one over the years, starting from 1908 as radical APR, current days to minimally invasive surgical techniques and watch and wait therapy for patients, those who have had clinical complete response. All this is possible because of the improvement of the imaging technology to accurately stage the cancer and less aggressive radiotherapy plans and availability of newer chemotherapeutic agents, as well as because of important clinical trials which showed the efficacy of treatments over the years. Once initially diagnosed, next step is primary staging. So local staging done with high resolution MR rectum, and distance staging is done with CT chest, abdomen and pelvis. And those who have oligometastatic disease, MR liver is mandatory, in particular to assess exact number and location of the metastasis by using hepatobiliary contrast. FDG PET CT is performed in selected patients. FDG PET MRI is a new emerging modality where the local staging as well as distance staging can be performed at one setting, thereby synchronously acquiring PET and MRI data. MRI is also useful in restaging following chemoradiotherapy, watch and wait patients, minimal invasive surgery patient follow-up, and those who have had radical surgery will be followed up with CT, chest, abdomen, pelvis, and FDG PET. Because of the higher spatial resolution, MR can show us exact location of the cancer, in particular distance to the inferior margin of the tumor from the anal verge and the anorectal junction, and hence locating the tumor to lower, upper, and mid-rectum. And in case of anteriorly invasive cancers, it will show us the involvement of the peritoneum as well as the adjacent structures. In addition to the T-stage tumor composition, identification is also important, and MR will show us good and bad prognostic factors. Majority of rectal cancers are non-mucinous and they will be seen as T2 intermediate signal lesions, whereas lesser percentage, 5 to 10% of rectal cancers are mucinous and they are very bright on T2 weighted imaging. Differentiation is important because these tumors are poor sensitive for chemoradiotherapy and therefore have aggressive histology as well. Histologically, two types, mucinous and signet ring carcinomas, depending on the mucin content, but we can't differentiate these two cancers separately from MR. Sometimes in the same cancer, we will see mucinous and non-mucinous component. It was long thought that MR cannot differentiate accurately T1 from T2 tumors and EUS is better, but because of the high resolution of the images, we can identify the mucosa, submucosa and muscularis propria surrounded by mesorectal fat and mesorectal fascia. But most of our patients, we only see two layers, submucosa bright, muscularis propria dark, and we look for continuous submucosal layer as a bright stripe underneath this tumor. Therefore, this becomes T1, whereas here bright submucosal layer is lost and hence it's a T2 tumor. Anyhow, these tumors have good prognosis and by the time of presentation they do not have distant metastasis or nodal metastasis. Recently, adding another sequence by using gadolinium enhancement has taken as an added value because with the gadolinium we can identify the nicely enhancing submucosal layer, in this case underneath the tumor. Submucosa is intact and therefore it's a T1 tumor. This one looks like a T1 tumor on the pre-contrast, but after contrast we can see disruption of the submucosal layer and therefore the tumor has invaded into the muscularis propria as shown in the pathology here. So recent studies have shown that EUS and MR has similar sensitivity and specificity for T staging, whereas MR has slightly better sensitivity and specificity for N staging. When the tumor extends beyond the muscularis propria, that's a different scenario. T3C tumors and T3D tumors have high risk of local recurrence, and any T3 tumor with mesorectal fascia involvement has high risk of local recurrence. Here are some of the examples. This tumor, a upper rectal cancer with extension anteriorly into the peritoneum, hence a T4 tumor. And this tumor is also midrectal tumor but anteriorly involving the peritoneum. When we go further down, we can see involvement of the mesorectal fascia laterally here. This tumor is a midrectal tumor where the invasive margin is around 7 to 9 o'clock position involving the mesorectal fascia. In case of lower rectal cancers, even early T3 cancers can invade the mesorectal fascia because of the surrounding mesorectal fat is sparse. Therefore, in lower rectal cancers, what radiologist does is they will give you a detailed anatomical description of the tumor extent. So stage 1, when the tumor is confined to the wall but not full thickness, it may be T1 or early T2. In case of T2 tumors where the tumor involves the full thickness, it becomes stage 2. And when the tumor invades the intersphincteric space or lies within 1 millimeter of the levators, it becomes T3. But when it invades the external sphincter but within or beyond the levator, it becomes T4. So stage 1 and 2 is considered as MR lower rectal cancer resection plane safe. 3 and 4 resection plane is unsafe. So safe patients can have surgery, sphincter preserving surgery, whereas unsafe patients should have neoadjuvant chemoradiotherapy followed by surgery, or if there is a complete response, even watch and wait with a view of organ preservation. Here are some of the examples. Here lower rectal cancer only invade the internal sphincter. The external sphincter complex and intersphincteric plane is preserved. This cancer has invaded the external sphincter on the left side, whereas this one has invaded the levator ani muscle on the left side. Other important thing to look at is the involvement of the mesorectal fascia. when the tumor tumor to the mesorectal fascia distance is more than 1 millimeter, mesorectal fascia is clear. If it's less than 1 millimeter, mesorectal fascia is involved and there is higher chance of local recurrence. Here are some of the examples where mesorectal fascia is involved by the tumor. This one is an abnormal lymph node. Here is a tumor mass as well as lymph node. It's important because this is one of the most important factors that govern the successfulness of TME surgery. Other poor prognostic factor is presence of tumor deposits, so MRTD. These are separate tumor masses away from the tumor surrounded by the venous structures. There is an increasing evidence that this is also a very poor prognostic factor. Next poor prognostic factor is extramural venous invasion, where the tumor has invaded into enlarged adjacent venous structure. These are the examples of EMVI. Histopathologically, this is equivalent to lymphovascular invasion. The lymph node, two things we are looking at in lymph node staging is size and the morphology. Instead of having smooth margin oval shaped lymph node, we are looking for irregular margin lymph node with a heterogeneous signal and loss of fatty hilum. The size wise locoregional lymph nodes cutoff is 10, lateral pelvic node 7 and non-locoregional lymph nodes 10 mm is the cutoff. But if the lymph nodes within the mesorectum is small, then 5 to 9 mm we need to have 2 morphological criteria. Less than 5 mm we should have 3 morphological criteria to call it abnormal. It's important to know where are the tumor, in particular in the lower rectal cancers in relation to the dentate line. If the tumor is extending below the dentate line, inguinal nodes becomes locoregional. But unfortunately in MRI we cannot identify where the dentate line is, so it's important for you to mention it in your request form. Diffusion weighted imaging is helpful to identify small lesions and lymph nodes, but we cannot differentiate benign from malignant lymph nodes. This is very useful in assessing treatment response because of high cellularity of the tumor. It will be bright on DWI and there will be signal reduction in ADC, and we are looking for complete opposite of this in patients with response. So locally advanced patients, rectal cancer patients will have neoadjuvant chemoradiotherapy or then followed by TME resection and adjuvant chemotherapy. Or some patients will have nowadays total neoadjuvant treatment, and complete response patients could go for watch and wait pathway. So because of edema, inflammation, necrosis and fibrosis in early stages after treatment, interpretation is difficult, so we had to wait 6 to 8 weeks after completion of treatment to stage. In MR, what we are looking for the presence and absence of a tumor signal as well as fibrosis. This is called MR tumor regression grade. Grade 1 is complete resolution of the tumor and the wall is completely normal. Grade 2 is dark fibrosis within the tumor and no tumor signal seen. Grade 3 is majority of the signal is dark fibrosis but very little tumor. Grade 4 is majority of the residual signal is the tumor but very little fibrosis seen. So grade 1 and 2 is considered as complete response. Grade 3 is near complete response. Grade 4 is no response. Grade 5 is also no response. We are actually because it's the tumor signal retained throughout the tumor. Even though there is a tumor size reduction, we only look for presence of tumor or fibrosis. Similarly, we look at the response of the DWI. This is the baseline to compare. So complete response, complete disappearance of DWI signal. Near complete response is only tiny focus of residual DWI, and incomplete response is the presence of DWI high signal even though the tumor size looks smaller. Then nodal response is also the same. Complete response is complete non-visible lymph nodes, so very few small lymph nodes. Near complete is reduction in size. Incomplete response is persistent of lymph node. So after all, your radiologist will give you YMR, tumor, node, EMVI, tumor deposits, and MRF status. In particular, within the fibrosis, even though we think that there may not be tumor, there may be microscopic tumor cells. Therefore, if there is dense fibrosis touching the mesorectal fascia, we report it as positive mesorectal fascia, whereas in this case, very thin fibrotic band here, tumor is fibrosed, and this is a mesorectal fascia negative post-therapy patient. Then watch and wait therapy or approach. The role of imaging is actually to identify the complete and near complete clinical response, and then it has a role in follow-up. There are different follow-up regimes. They should be followed up closely for 5 years. I'm not going to talk too much because this will be, I'm sure this will be discussed in the other lectures. Quickly come to the FDG PET-CT in rectal cancer. FDG PET is not usually used for initial diagnosis, but it may be, rectal cancer may be diagnosed in a PET scan, which is done for other reasons. Similarly, precancerous adenomatous polyps may be detected incidentally in a PET scan, which is done for other reasons. So for the initial staging, PET scan is unsuitable because it's not good for anatomical details. This is very much useful in follow-up patients. As we know, FDG accumulation in the tumor cells is based on glycol metabolism. Therefore, if we have high FDG activity, that means that the cancer growth rate is high and aggressiveness is high. So other indication for FDG PET is detecting recurrence in patients. Those who are having rising CEAs, but on CT we can't identify any tumor. It's also useful in radiation therapy planning. Sometimes PET scan is done for potentially operable synchronous metastatic disease patients, because if the patient is having liver metastasis, oligometastatic disease, those who are eligible for liver surgery, then they should have PET scan to rule out other synchronous metastatic disease elsewhere. So here's an example of a liver lesion which is identified by the PET scan but not in CT scan, but accuracy for PET identifying lesions is size more than 1 centimeter, MRI superior, MRI can identify lesions less than 1 centimeter. So those who have less than 4 lesions, less than 5 centimeter, no extrahepatic disease, can have neoadjuvant therapy and then go for metastatic. Here is a lung nodule with PET avidity. Lung is the second most site associated with other metastases from rectal cancer. For PET scan, nodule should be over 8 millimeter to identify definitely. CT can do a better job because it can identify 2 to 3 millimeter lesions. Few words about FDG PET. We can do whole body T1 and T2 weighted imaging in addition to our normal staging protocols, as well as post-contrast imaging, and we can do dedicated sequences with hepatobiliary contrast to the liver. This is helpful for staging as well as restaging after chemoradiotherapy to identify recurrence. And therefore, this is because we have got anatomical details and metabolic activity. It's good for selecting patients for rectum sparing approach. M staging is not good with the MRI, therefore we need to do a CT chest. That brings us to the conclusion. So the gold standard for diagnosis of rectal cancer is endoscopy, biopsy and histology, but imaging has an important role as we discussed. So imaging modalities we use is MR, CT, endoscopic ultrasound or PET-CT. MR has its own strengths because it can identify the mucosa, submucosa, muscle layers, so that critical T staging. It identifies the mesorectal fascia where your CRM will be, and therefore we can actually predict the resectability of the tumor. EMVI, nodal state and liver metastasis are also important, and they are poor prognostic factors. And also MR is useful to assess the efficacy of therapy by looking at the proportion of the residual tumor and fibrosis. Of course, availability is may not be available all the time and not suitable for lung metastasis. Strength for PET scan is it shows metabolic activity of the tumor, and therefore it's good for assessing the nodes and distant metastasis, and also good for assessing the metabolic response after therapy. But unfortunately, sometimes there may be unwanted indeterminate findings like lymph nodes elsewhere, which will give us a problem. And its poor anatomical details makes it unsuitable for local staging, and small lung and liver mets may not be identified in PET scan. Of course, at the end, it's not only radiologist duty, but radiologists have a very important role here. Discussion of patients' findings in a colorectal multidisciplinary meeting is mandatory because each patient is different, and depending on their other comorbidities, different treatment regimes will be prevailed for each patient. After all, once we take a decision in the colorectal MDT, it's mandatory and it's very important to discuss with the patient, because patient is the ultimate person who is deciding the therapy once we given the options. With that note, I thank you for your kind attention. Enjoy your rest of the day.
Thank you very much, Dr. Padmini Hewavitarana, for that very informative lecture. She is not available for questions at the moment, so we'll go for the questions after the next talk.
Good afternoon, ladies and gentlemen. And next we have Dr. Rodrigo Perez from the University of Sao Paulo, Brazil, to talk on total neoadjuvant treatment in colorectal cancer.
Hi, everyone. Now I'm going to talk about total neoadjuvant therapy for rectal cancer. These are my disclosures. Now, when we talk about total neoadjuvant therapy for rectal cancer, we have to clarify one thing right off the bat. Number one, we're talking about non-metastatic disease. And number two, we are talking about microsatellite stable disease. So these are the patients that are actually candidates for a total neoadjuvant therapy approach. Now, why are we asking whether all patients need total neoadjuvant therapy if they have a rectal cancer? Well, if you look into the guidelines, and this is the currently available NCCN guidelines, the only option is TNT. There is no other option for patients with tumors that are below the peritoneal reflection. So you either receive TNT with consolidation or with induction chemotherapy. Now, let me go back a bit in history. Chemoradiation therapy solved one and only problem in terms of rectal cancer: local control. There was a big problem because none of the trials with chemoradiation therapy were able to improve survival in the setting of total mesorectal excision. So there was a big quest for improvements in survival. And most of the trials that were designed were done to improve survival. And the idea of TNT all was to bring adjuvant chemotherapy to the beginning of treatment so that we could improve survival by tackling micrometastatic disease up front. So if you look at the two trials that compared TNT to chemoradiation therapy, old style chemoradiation therapy, the PRODIGE 23 and the RAPIDO trial, both incorporating TNT, slightly different approaches, Prodige used induction chemotherapy, Rapido used consolidation chemotherapy. The type of chemo was different between the trials. And while the Prodige study used long course radiation therapy, the Rapido trial used short course radiation therapy in the TNTR. Now, to make a long story short, both trials were positive. They were successful in showing improvements in distant metastasis-free survival. This is the Prodige 23 distant metastasis-free survival curves, and you can see a 7% improvement when you deliver TNT to rectal cancer patients. And the exact same differences were observed in the Rapido trial. 7% improvement in distant metastasis-free survival among patients receiving short course radiation therapy with consolidation chemotherapy. So there was still a question whether induction is better or consolidation is better. The idea of giving induction, starting off with chemotherapy, is to deliver chemotherapy up front and tackling up front micrometastatic disease, as opposed to waiting 6 weeks of chemoradiation therapy, long course chemoradiation therapy, and then offering these patients systemic chemotherapy. Well, excuse me, both trials, the OPRA trial and the German trial, showed no differences in terms of disease-free survival when you treat patients with upfront chemotherapy, induction, or consolidation. So, meaning that waiting for the 6 weeks for the long course chemoradiation therapy makes no harm to patients in terms of disease-free survival. So it's actually very safe to wait for the 6-week long course chemoradiation therapy and then consolidation chemotherapy. It makes no difference. Either one is good. And that's why we still didn't know whether induction was better than consolidation, because they had no differences in terms of survival benefit. Now, if you think about it, TNT is like a package. It's like a menu. When you go to McDonald's and they offer you the cheeseburger and the fries, the menu has both components, the radiation therapy and the chemotherapy. If you think about it, what improves survival is probably the chemotherapy component. The radiation therapy was never able to improve survival. It was the amount or the significant increases in the amount of chemotherapy that actually improved survival. So in patients where you don't need radiation therapy, applying or giving these patients the package of both components may be unnecessary. So consider this patient, for instance. This patient has a T3N1 disease. The aim is to improve survival, but there's really no need for radiation therapy. You can see how clear the mesorectal fascia is. And the problem is, when we give these patients the package, both components together, you end up having to deal with frequent anastomotic leaks. This is an anastomotic leak of my own, and this is another one. You can see clearly where the anastomosis is, and there's a second hole. And the second hole is actually the leak, which is often difficult to manage. When we look into prospective randomized trials, there is data to suggest that the radiation is an independent risk factor for anastomotic complications. This is the FORWORK study, the Chinese study, showing that patients that did get radiation therapy were more likely to have problems with their anastomosis. And this is quite relevant, because at the end of the day, even though you are able to perform a primary anastomosis, this does not mean that the patient will not need a definitive stoma. This is interesting data coming from France, showing that despite the fact that only 10% or 8% of patients really needed a definitive stoma, by the end of 10 years, those figures tripled. And they tripled because of anastomotic complications. So when you give the package of TNT, radiation therapy, with chemotherapy, but all you needed was the chemotherapy component, I'm a bit worried that we are giving too much treatment for patients who really don't need the package. They don't need the French fries with the cheeseburger. They only want the cheeseburger. But we are putting all together in a package, and that's concerning. Now, the second reason why we want to give TNT has to do with response. Now, do we need response for all patients with with rectal cancer? Well, that's the point, response, where I believe both components of the package are relevant. I think chemotherapy plays a role, and I think radiation therapy plays a role. And I fully agree that these patients need the package if what you want is response. Now, there are only, in my view, two situations where you really need response. First situation are those patients who have a threatened margin. And you can see here, there is a tumor deposit very close or threatening the mesorectal fascia, or even compromising the mesorectal fascia. And this patient clearly needs a response from treatment. And therefore, I believe that the two components of the package, TNT, make sense. If you remember, chemoradiation therapy already had a significant impact in local recurrence rates. And as a matter of fact, there's lots of data showing that the single independent risk factor for a local recurrence is a threatened margin. A tumor that is less than 1 millimeter from the mesorectal fascia is at high risk for a local recurrence. So that's why I believe all patients throughout the rectum, wherever the tumor is, and there is mesorectum around it, if the fascia is threatened, those patients need response, and therefore they benefit from TNT with the two components of the package. What do we want to achieve? This is what we want to achieve. You can see on your left, the tumor is somewhat threatening the mesorectal fascia, and by treating that patient with TNT, you can clearly see we've increased the safety of doing total mesorectal excision, and we can now safely perform TME with a much lower risk for a local recurrence. Now, if you're thinking about TNT for local control, I should make a statement here. Please don't use the Rapido trial regimen. And why? Well, I honestly think that the Rapido trial has some significant problems. As you have heard, and probably some of you did listen to the actual presentation of the trial at ASCO a couple of years ago, the first slide mentioned that local control was already not a problem in rectal cancer management. Local control was established quest from chemoradiation therapy. Well, the problem with the Rapido trial is even though they did show an improvement in distant metastasis-free survival, they had problems with local control. Now, I want to show you some data that was present already in the first manuscript at Lancet Oncology. Look at this table. Patients managed by old-style chemoradiation therapy or the Rapido regimen had similar baseline staging. They had similar R0 resection rates. They had double complete pathological response rates. Well, if you add those figures, similar baseline, similar R0, double pathological complete response rate, I was expecting that the experimental arm had lower local recurrences. However, they did see higher local recurrence rates among patients who underwent the Rapido trial. If you look at the figures in the first publication, they are somewhat hidden in the tables. However, a subsequent publication really shows that even among the R0 resections, patients who underwent the Rapido trial had higher rates for local relapse. As a matter of fact, when they did a multivariate analysis, the only two features associated with a local recurrence in the Rapido trial was the fact that they received the experimental arm or enlarged lateral pelvic nodes. So that's why I think if you need response, there's a risk for a local recurrence, you should be giving these patients TNT, but long course chemoradiation therapy and consolidation chemotherapy, not short course, not induction. Why do I say not induction? Well, there's a second indication that I believe patients may benefit from TNT. They also need response, not because they are at high risk for a local relapse, but because you're interested in organ preservation. So if you're interested in delivering treatment and maybe avoiding TME altogether, you might be looking at TNT as the best way of getting there. And when you look at the data, looking and comparing induction versus consolidation, both studies, the German study and the OPRA trial in the United States, both showed that consolidation is better than induction chemotherapy in achieving a complete response. The German trial had higher rates of complete pathological response, while the OPRA trial in the US had a higher rate of a complete clinical response after consolidation chemotherapy. So apparently, long course chemoradiation followed by consolidation chemotherapy is also better in terms of achieving a complete clinical response. By the way, for those of you still interested in achieving a complete pathological response, I cannot disagree more. There's absolutely no benefit to the patient by achieving a complete pathological response. The only clinically relevant endpoint we should be looking for these patients is really the achievement of a complete clinical response. And when we look at the OPRA trial, patients who got long course chemoradiation followed by consolidation chemo had more than half of the patients achieving a complete clinical response and undergoing organ preservation. Now, just a short message. I don't believe in organ preservation for the entirety of the rectum. Slightly different here. Patients who have a threat margin all throughout the rectum should get TNT. But if you're interested in TNT for organ preservation, only those patients who have tumors very close to the anorectal ring, as indicated by this red dotted line. These are the patients we believe are best candidates for organ preservation strategies. Number one, because the benefits outweigh the risks. And number two, because you have an important assessment tool, which is your finger. So when we published our data showing a 50% complete response rate using consolidation chemotherapy, it wasn't called that way at that time. You can see the date of the publication of 2013, nearly 10 years ago. We showed a 51% complete response rate. And now the OPRA trial, almost 10 years later, showed the same 50% organ preservation rate. What are the differences here? Well, our data was exclusively with 5-FU-based chemotherapy, whereas the OPRA trial used combination of 5-FU and oxaliplatin during consolidation. And this is why we currently have an ongoing randomized trial open here in Latin America, comparing consolidation chemotherapy with and without oxaliplatin. And I am suspecting that there is no benefit of adding oxaliplatin to these patients. And the only thing that we're really seeing among them is increased toxicity associated with the oxaliplatin. So at the end of the day, if you're interested in organ preservation, perhaps the best alternative here is consolidation, as I showed you, and long course chemoradiation therapy because the data is more robust in terms of organ preservation with long course radiation. Yes, there is an ongoing trial comparing short course radiation and long course radiation, similar to the Rapido regimen, and we're very much looking forward to see what's going to happen to that trial, to see whether patients with short course do any better than long course in terms of organ preservation. If they do the same, I would challenge you that I would never use short course if the chances are the same of organ preservation. But as I shown you before, the risk of a local recurrence after TME in the incomplete responders is higher. So at the end of the day, two important messages. These are the patients I believe need the two components of TNT. If the mesorectal fascia is threatened throughout the rectum, those patients need the two components of TNT, long course radiation therapy, consolidation chemotherapy. If you're interested in organ preservation for the very distal tumors, long course radiation therapy and consolidation chemotherapy. And finally, even though not contemplated in the NCCN guidelines, if you have a patient with nodal disease or high risk features, but the mesorectal fascia is clear, there is apparently no need for radiation therapy. And we do know from the Mercury study that those patients do very well in terms of local recurrence rates. There is absolutely no need for radiation therapy among those patients. TME does the job with very good local recurrence rates. There's absolutely no need for increased risk of anastomotic complications among those patients. This is the data from the Mercury study. The OCUM study in Germany showed similar outcomes. Patients with clear mesorectal fascia, very low local recurrence rates. So there's clearly a subgroup of patients that probably don't need radiation therapy component of the TNT, and therefore we could basically offer them TME followed by adjuvant therapy. Well, then a recently published study in the New England Journal of Medicine recently presented at ASCO, the Prospect trial compared patients to chemotherapy alone at the neoadjuvant setting compared to the old style chemoradiation therapy. Now, there are a few problems with this study. Number one, those patients, they had all clear mesorectal fascia, meaning that they didn't need radiation therapy, but they still received in the control arm chemoradiation therapy. That's number one. Number two, it was a non-inferiority trial. I probably would challenge the authors that the adequate trial design here was a superiority. I was expecting to see a distant metastasis-free survival benefit among patients receiving chemotherapy alone up front as compared to radiation or chemoradiation therapy, old style. However, you can see here there were really no differences in terms of disease-free survival at 5 years. And as you would expect, there were no differences in local recurrence. Why? Because those patients were never at risk for local recurrence because they all had a clear mesorectal fascia. So at the end of the day, I think that the Prospect trial did not add significantly to our knowledge. I also have a third commentary here. I was expecting to see a third arm in the Prospect trial, which would have been TME upfront versus adjuvant therapy. So in the third arm, compared to the preoperative FOLFOX, I was expecting to see if there's any benefit of giving these patients chemotherapy before TME. Otherwise, I would probably offer them TME followed by adjuvant therapy, depending on the pathological findings of the resected specimen. So at the end of the day, TNT is definitely a treatment that has an impact in survival. But remember, the impact in survival is driven by chemo and not by radiation therapy. I honestly think that TNT is best suited for patients who are high risk for local recurrence. Therefore, I would definitely offer TNT for any patient with a threatened margin. Be careful. I would never use short course radiation in those patients because of the findings of the Rapido trial. If you're interested in organ preservation, definitely start with TNT, long course radiation, and consolidation chemotherapy. And finally, I still believe there is a place for TME up front. I still don't think there is data to support neoadjuvant chemotherapy alone, even among patients with N positive disease. Maybe there will be a place for chemotherapy up front in patients with high risk, such as T4 disease, or maybe even EMVI or extensive EMVI, but we still really don't know which are those patients. So at the end of the day, if the mesorectal fascia is clear, even though there are risk factors for systemic relapse, I still believe there's a place for TME up front, followed by adjuvant therapy, depending on the final pathological findings. So at the end of the day, well, did TNT replace chemoradiation therapy old style? Definitely. I think there's really no place for normal or old style chemoradiation therapy. And the second question is, do all rectal cancers need TNT? I honestly believe no. Patients, even though that are microsatellite stable and no metastatic disease, if they have a clear mesorectal fascia and there is no interest in organ preservation, those patients do not need the TNT regimen and maybe are best fit for a TME upfront followed by adjuvant chemotherapy, depending on a pathological stage. If the mesorectal fascia is threatened or there is an interest in organ preservation, definitely TNT and definitely long course followed by consolidation chemotherapy. I thank you very much, and I'll be happy to take any questions.
That was a fabulous talk by Dr. Perez, but unfortunately he's not available for questioning at the moment. But we do have a very senior oncologist with us, Professor Jayanta Balawardena. So if you have any questions regarding total neoadjuvant treatment for rectal cancer, you can please forward them to him. So could I ask you a question? What is your experience with TNT in the local setting? What sort of a regime do you use? And what are the hurdles you have in the local cancer care setting to establish total neoadjuvant treatment?
Actually, we are in our setting, we are using two regimes depending on the oncologist's discretion. Either it is capox, that is capecitabine and oxaliplatin, or sometimes we use FOLFOX. We use both these regimes, okay, but there's with all the given data, there is hardly any difference between those regimes. But only when you're using the capox, sometimes you can get a bit of a neuropathy because you are using a higher dose of oxaliplatin. Oxaliplatin is known to give a fair degree of neuropathy, so that is the only issue. But by and large, in my unit, I always prefer to use FOLFOX because that is a safer, although it's a sort of a prolonged chemotherapy regime, it is safer as far as the long-term side effects are concerned. Because especially, I don't know, in the Asian setup, when you use a high-dose oxaliplatin, they tend to get some degree of neuropathy. And we may have to terminate the chemotherapy halfway, which is not beneficial.
Do you see many complete clinical responses and
yes.
organ preservation?
Now, actually, we started this total neoadjuvant therapy recently because for the last, maybe about 1 year, still we are not in a clear position to sort of publish our data. But having said that, now we have shifted. Now, those days it was conventional treatment with, either chemotherapy followed by radiotherapy or radiotherapy followed by chemotherapy. Now we are going for organ preservation type of, with, of course, with the discussion, having a discussion with the surgeon, we always, tend to follow the organ preservation pathway more and more.
Yeah.
What is the regime you follow? Is it consolidation or induction?
Well, that depends. We always discuss with the surgeon. In my opinion, there is no difference with this induction followed by chemoradiation or chemoradiation followed by induction. So that is the OPERA trial. OPERA trial very clearly says that both will give similar results.
How would you monitor during the course of treatment, sir?
Usually, after each and after each and every cycle, we do a digital rectal examination, and mostly after 3 cycles, we tend to do a MRI, high resolution MRI, to see whether there is any response. And if you are satisfied with the response, then of course we do continue. Otherwise, we'll have to go for something else, Because there is a triple assessment. One is the DRE, other one is the high resolution MRI, and a sigmoidoscopy. So we usually, at the end of 3 cycles, we do that as a routine.
Would there be a place for PET for complete pathological response?
Come again?
If you are in a survey after neoadjuvant chemoradiation.
Yeah. Now, usually there is so-called the 3T assessment by the Sloan Kettering. There can be three scenarios. Number one, there's a complete response. Then, of course, we can go for the watch and wait policy. Then, if there is a fairly good response, again with some risk, we can go for the watch and wait policy. But if we are not happy with the total response, then of course we'll have to go for surgical intervention.
There's also place for scar excision and assessing the complete
That is very
pathological
clearly
response.
shown on Sloan Kettering criteria, 3T criteria.
Yeah, Dr. Padmini Hewavitarana is online. Thank you very much, madam, for that very informative lecture. Is there any questions from the audience for the radiologist, Dr. Padmini Hewavitarana? Yeah.
I'm sorry that I couldn't really join earlier after my lecture.
Hello, thank you for your lecture. I really enjoyed it. You talked about using MRI scans and PET combined with PET and rectal cancer, but you've also said that MRI scan is not very good at picking up any abnormalities less than 1 centimetre, but of course many of the nodes involved in rectal cancer will be less than that. So is there a benefit of PET with rectal cancers?
No, lymph node detection with MRI accuracy and sensitivity is at a lower level than expected, but less sensitive MR for metastatic disease, in particular the lung metastasis, so that if we are following up, we can't do MR, but we had to do CT, chest for chest metastatic. But the liver MR is very much better than CT or PET scan. Because PET scan you have to have at least 1 centimeter or more, but MR we can detect with the use of routine sequences as well as DWI and hepatobiliary lesions less than 1 centimeter. But the lymph node stages, MR is useful, even though it's not very accurate. We are looking for morphology as well as size criteria. Now that the studies proven that by combining size and morphological criteria, sensitivity and specificity has increased, and it's in the range of those still 65 to 80. It's a wide range.
Yeah, if I can ask a question, madam. Say now, when we are now talking about the CRM and the EMV invasion, what kind of training do you recommend for a radiologist before they start reporting on these MRI rectums?
I think it should be included, because at a training center should be, especially those who have returned from abroad training, they should have sort of exposure to MRI. In our hospital, actually, we do have a lot of Sri Lankan trainees coming here after completion their MD, so they are allowed to report MRs, and especially at the initial stages, they will be supervised directly, and they can initially report, but without releasing it to the fax system, their reports will be reviewed, so that they'll get a sort of hands-on kind of a training before allowing them. But I think experience will give you a accuracy high as in any other thing. Having report a lot and having a senior person will give you a sort of better benefit.
Right, thank you, madam.
Of
One more
course,
question,
other
Doctor.
thing is you can actually, there are workshops online as well as on person. So we'll give you a sort of hands-on experience if you want to enhance the confidence of your reports. But the thing is, because Emma, we are having only difference is with the Emma is differentiation of T1 and T2 and T2 and T3, very early T3 tumors, because sometimes we might overcall T2 tumor as T3 because of the surrounding desmoplastic reaction, as well as we might undercall T3 tumor as T2 because we cannot see the pathological microscopic invasion into the mesorectal fascia. So those deficiencies are there, but by careful observation around, in particular the bowel wall, to see whether the muscularis propria is intact, and we can see very bright mesorectal fascia adjacent to the bowel wall without any irregularity will be the key. In terms of mesorectal fascia, because we can see mesorectal fascia clearly very high resolution MRs as a dark line, so that we have to sort of measure the distance very carefully. It would be the shortest distance what we measure to see whether it's involved or not. In case of tumor deposits, they are irregular. They are usually within the mesorectum. Once again, if they are present close to the mesorectal fascia, similarly like a 1 millimeter cutoff, then we can report as mesorectal fascia involved. I think the most difficult part is differentiation of T2 tumors from very early T3 tumors like 1 millimeter extension beyond the muscularis propria. 3 millimeter is not different. Certainly 5 millimeter after is easy.
Thank you, madam. Dr. Bhavanthia.
Yeah, one more question. Do you follow any specific protocol in this rectal cancer staging, MRIs?
Yes, we do have specific protocol in the sense 1.5 Tesla or 3 Tesla is both good, but there are advantages and disadvantages, but specific protocol is we mainly depend on T2 weighted imaging. They should be very high resolution, meaning that slice thickness is actually less than 3 millimeter. And then the other key in the MRI is actually to get exact axial image, not to the pelvis, but to the axis of the tumor, so that we are not making T2 disease like T3, because if your angle is incorrect, then we will overestimate the tumor. So it's very much important for the radiologist to supervise the case and look at the tumor first in the initial sequences, then take proper imaging, exactly perpendicular and parallel to the long axis of the cancer.
Thank you, madam.
Contrast enhance is mentioned, but actually in our hospital we haven't started yet contrast enhance studies.
Yeah, thank you very much. And our next speaker is Ms. Claire McNaught from Harrogate and District NHS Foundation Trust UK, and she will be talking about organ preservation in rectal cancer, the other dimension.
Thank you very much, and thank you to the committee for your your great invite and your hospitality that you've shown to me so far. It's a wonderful country, so thank you. So I've been taught, we've mentioned it a few times, I've been asked to talk to you a little bit about organ preservation. Now, in my lifetime, which is now 50 years, sad to say, we've made huge strides in colorectal cancer. Mortality rates have gone down dramatically by over 45% in my lifetime. But it's all not a rosy picture, because unfortunately the surgery that we do for patients with colorectal cancer does have side effects. And I'm just going to show you some data here. This is from the national database we keep, called the MBOCAD database of colorectal surgery in the UK. And as you can clearly see from this data from 2022, there's a 3% mortality rate. There's an 8% return to theatre after elective surgery. There's an 11% readmission rate, and over 45% of our patients will stay over 5 days. So the surgery has a massive impact on patients. And then when we specifically look at rectal cancer, well, it's not really wonderful. 37% will have a permanent stoma at the time of their initial surgery. But many patients, as we've heard, will have a divergent ileostomy. And the current data in the UK is that if you have a defunctioning ileostomy, at 18 months, 47% of them are still not closed. Why is that? Well, partly that's because of maybe the COVID backlog, but a lot of that's because of either anastomotic complications or of local recurrence. So it's not a great picture. So we have to be honest about what we're doing as surgeons. And also on top of that, there's also other morbidity, especially in men, the sexual dysfunction, the urinary dysfunction, persistent perineal sinuses, and people who have AP resections. And when we think of the epidemiology of cancer and rectal cancer, we know that 1 in 4 new cases by 2030 will be young. They'll be less than 50 years old. So we've got to just get away from talking about just survival, which is, of course, incredibly important. But we also need to start thinking about quality of life, and that's where organ preservation comes in. So what is organ preservation? Well, essentially, the international consensus definition is that your rectum stays intact, you don't have a TME resection, and you don't have a permanent stoma, whether that be a permanent stoma or a never reversed ileostomy. And I'm going to take you through some of the sentinel trials and how we've looked at organ preservation. I can't show you all the trials, I don't have time for that, but hopefully I'll give you a flavour about what's happening in this space. Now, as we've heard already, most of the strategies for organ preservation about trying to induce, using other types of treatment, this complete clinical response. So, and that's, as my previous colleague just says, you determine that clinically by a rectal examination, by looking at the rectum endoscopically and showing either no mucosal abnormality or just a small scar, and seeing positive changes in your MRI showing regression of the tumour and fibrosis and no lymph nodes. Biopsy is not required and actually may be unhelpful. So these are pictures here of a complete, a near complete and an incomplete clinical response. You can only tell a complete pathological response when you do a TME and take out the specimen. So obviously we really have to go on the clinical findings for these patients. So let me just talk you through the sort of stage-wise how we've looked at saving the rectum in our patients. So the first strategy is just local excision on its own. There are lots of techniques that we use now for local excision, TEMS, TAMIS, and transanal resection, all very common. And the reason we like them, well, that the patients do well, there's less major complications. But the problem with just using a local excision on its own is that it's perhaps a viable option for someone who's got a T1 tumour, when we know that their lymph nodes, positive lymph nodes will probably be less than 15%. So the risk benefits of doing a TME are really very close. But as soon as you start to get increases in your T levels, T2s and T3, your positive lymph node status really stops this from being an option for organ preservation. So fine for perhaps T1 patients, you can keep a close eye on them, but not for other T grades. So we had to think about doing something different, so why don't you give them chemoradiotherapy and see what happens to them? And we've already heard from South America, Haba Gamers really is a person who pioneered this chemotherapy and watch and wait. She basically started an international watch and wait database made up of previous patients and new patients since then, and looked at what happened to patients who had complete clinical response, looked at their local recurrence rates and their overall survival. This study in The Lancet summarised the results of that international database. Over 880 patients from Brazil, the Netherlands, the UK and other centres. And as you can see here, there were a number of different T grades, but mainly T2 and T3 tumours. And essentially this summarises the results. What they found was that if you had chemoradiotherapy and you had a complete clinical response, that your local regrowth rate was about 25% in the first 2 years. So 3 out of 4 of your patients didn't relapse. If it did come back, it came back in the bowel wall mainly at 97%, only 3% came back regionally. They had a distant, these patients had a distant metastatic rate of about 8%, and that's what you see with TME on its own, so very similar to TME at 3 years. And their 5-year survival was good, 85%, so this is all very encouraging. From this data, they looked at the patients who did have a local recurrence. There was 213 of them, and they had data on 140, and what happened to them was 31% could have their local recurrence treated with local excision. Of those who had salvaged TME, most of them were R0 resections. And basically, what they concluded was that if you have a complete clinical response after chemoradiotherapy, it does suggest that you've got favourable tumour biology. It doesn't guarantee a complete pathological response because 1 in 4 people will relapse. So you do have to keep a very close eye on this patient group. But what was really key from this data was that the risk of unsalvageable local recurrence was very low. And this is what makes it an option for watching and waiting, and because you can still salvage the patients. So we've kind of moved on from then, and people say, well, that sounds great, so why don't we give them chemoradiation and then also do local incision combined? Makes absolute sense. And there was a couple of seminal studies, the TREC study, but I'm going to show you the CART study here, which took early rectal cancers, so T1 and T3, N0 and staging, and they gave them neoadjuvant chemoradiotherapy. And then those that had a good clinical response went on to have a TEMS resection 8 to 10 weeks after the chemoradiotherapy. They looked at the specimen, and those who had a T0 or T1, they just continued to follow them up. And those that had any other adverse histology went for major surgery. And what did they find? Well, they started off with 55 patients, 2 patients died and 2 were lost to follow-up. So 51 had chemoradiotherapy, 47 went on to have a TEMS, and that diagram shows you what happened to them. Basically, 30 of them had a very good response, either T0 and T1, and of the ones that didn't, the 17, 8 of them went on to have surgery. They chose to have surgery, and they had no residual disease at all in their specimen. The other patients chose not to have surgery. Now, this was the first study that actually showed that having chemoradiotherapy and local excision isn't without its risk either. They do have complications. So they had 2 deaths with the chemoradiotherapy, one from sepsis and one from arrhythmias. Many patients have at least grade 3 toxicity, and there were quite a high rate of post-operative complications in terms of from the TEMS, like rectovaginal fistulas, bleeding and abscesses. So this type of organ preservation isn't without risk. There's quite a short follow-up from this study, but again, what they basically showed was 55% of the patients were able to preserve their rectum. So really, in terms of a conclusion from chemoradiotherapy with local excision, that basically you can get organ preservation rates up to 66%. Local recurrences do tend to be salvageable in most cases. The 5-year survival data is comparable to those patients who have TME alone, but there is morbidity of chemoradiotherapy. This is a more up-to-date study published in 2020 called the GRECAR2, and this was the first prospective randomized control trial looking at patients who have had a good response to chemoradiotherapy and either randomizing them to local excision or TME. They classified a good response as a residual scar less than 2 centimetres, and they did a full TEMS resection of the scar. And these are their results, which are quite interesting. What they showed was there was absolutely no difference at all in sort of 5-year survival. There was no difference in local recurrence between those who had local excision or those who had TME resections. The one strange finding from this study was the metastatic disease rate, which is much higher than the other studies from rectal cancer, up about 18%, which really wasn't adequately explained, to be honest, in the paper. But when they actually subdivided histologically the specimens, what they found was that people who had more aggressive histology were more likely to develop metastatic disease, which kind of makes sense. But this result basically confirms that really there was no difference at all between the 5-year oncological outcomes between local excision or TME in small rectal cancers who had good responses. And it was basically, again, safe to continue a watch and wait, even if you have more aggressive pathology on your local specimen. And I think really one of the key studies in this type of arena is going to be the Star Trek trial. This is a multi-centre trial that's going on at the moment in the UK. And this is it's an unusual trial that it's a patient preference study. So we're asking patients, do they want to have surgery or do they want to have organ preservation if their tumours are T1 to T3 and less than 4 centimetres. And if they want to have surgery, they go for a TME. If they want to have organ preservation, they're being randomised either to long course or short course radiotherapy plus local excision. So that's a really interesting trial for the future. Looking forward to hearing the results of that. Now, just in the last few months, there's been another very interesting trial in the area of organ preservation that looked at the extra role of using brachytherapy or contact radiotherapy. This is the OPERA trial, and this is a phase 3 trial. It looked at T2, T3 tumours. They did actually even include some people with small N1 disease. And they basically looked at whether or not giving people chemoradiotherapy with either an extra boost of external beam radiotherapy or chemoradiotherapy with contact brachytherapy would do better. And in the brachytherapy group, they subclassified the tumours into those less than 3 centimetres and those greater than 3 centimetres. And that's the trial design there. But basically, they randomised 74 into each of the arms. And this is the survival curves here. This is the 3-year organ preservation rates. So overall for the study, they found that people who were given brachytherapy had an 81% chance of organ preservation at 3 years. But really interestingly, those who had tumours of less than 3 centimetres, if you'd given them brachytherapy, had a 97% organ preservation. Local recurrence rates did occur, of course, about 17%, but there was no non-salvageable local recurrence, and the distant metastasis disease was found to be about 9%. So this was really interesting that maybe using neoadjuvant chemoradiotherapy with contact brachytherapy might be a really very reasonable option in people with mid to low rectal cancers with less than 3 centimetres. The problem is there's very few centres that are offering this at the moment, and there's really an urgent need to look at this, not just in the UK, but also internationally. Now, we've also heard a fantastic talk just there about the role of TNT, this concept of total neoadjuvant treatment. I'm not going to go through it again because it was so well told to us earlier. But basically, both the Rapido and Podri's trials have shown that if you give TNT, you can increase your pathological complete response rate to about 25%, compared to about 12% with conventional chemoradiotherapy. So again, it's making organ preservation even more of an option. And this was the OPERA trial that Rodriguez had shown us earlier. This was the multi-center trial looking at this, looking at induction or consolidation chemotherapy. Again, the outcomes were disease-free survival and organ preservation. Basically, over 300 patients, over 150 in each arm. But basically, what the results were at 3 years was that there was about a 2% mortality rate with TNT treatment. So again, it's not risk-free. There was, as he also mentioned, there was no improvement in disease-free survival with TNT over historical controls, which I think was surprising. But many patients were able to go on a watch and wait. So, and what they found was a local recurrence rate for those who had induction chemotherapy, so those who had chemotherapy before chemoradiotherapy, had a higher local recurrence rate than those who had consolidation chemotherapy after the chemoradiotherapy. And the same was found for organ preservation. So basically, giving your chemotherapy after the chemoradiotherapy seems to be the better idea. And there was no difference in the 5-year survival. So again, TNT does have a mortality rate of 2%. It can have over 50% organ preservation rates, but definitely you should be giving your chemotherapy after your chemoradiotherapy. Now, the last strategy I'm going to talk about now is immunotherapy, and I'm sure we all were blown away by this paper from MSK looking at mismatch repair or mismatch deficient patients with locally advanced rectal cancer. They had 12 patients that they gave this PD1 program death, 1 inhibitor, 2 over 6 months, and look at those pictures. The tumours just melted away. And I'm sure that when I look at this has to be the answer to rectal cancer, doesn't it, rather than surgery? I'm convinced. Now, there was a few questions today about how do you follow up people after you're looking at an organ preservation. As a surgeon, I think we've all been making it up as we go along. Well, this was a paper, an international consensus paper in 21, that maybe gives us a little bit of a guidance. So you can see that if you are going to do a watch and wait, you really do have to have intensive follow-up. That means a clinical examination every 3 months, an endoscopy, an MRI every 3 months, and a CA for the first 2 years, with a CT annually, and then you can, after 2 years, you can start backing off a little bit in terms of your how you follow them up. But I find this very useful, because I think now although I would suggest that all these patients who are having organ preservation should be entered into a trial, if possible, I think we are actually now doing this now with patient choice. The other thing as a surgeon is about what happens if they get local recurrence. Can we salvage the situation? And this is a nice paper that was recently published showing a meta-analysis of 11 studies, almost 1,800 patients, that looked at salvaged TME, and basically they found that in terms of the surgery, there was no changes in terms of the morbidity and mortality, the leak rates or stoma rates, the conversion rates. But what they did find was that the operations are more difficult, there are longer operating times, and perhaps your nodal harvest and your TME specimen weren't as good. But it doesn't seem to make any difference in terms of your local or distant recurrence. So I find that very reassuring. So I hope today that I've taken you through some of the papers on organ preservation. I think this is definitely going to become a reality and something you have to think about in your MDTs going forward, especially for the early cancers and the low cancers that are within reach of your fingers. There's a lot of questions we don't know yet about how we can adequately better improve pre-op staging, how we can choose the best treatment combination for patients, and there's been lots of really interesting work getting done at the moment about using genetic or biomarkers to try and work out what the best treatments for these patients are. We don't know about the optimal timing for local surgery, or really the best ways to manage local recurrence, or what the long-term side effects are in terms of quality of life for all of these treatments. But certainly, it's a very exciting time to be a rectal cancer surgeon. Thank you very much. I'm happy to take any questions.
Thank you very much for that eloquent lecture.
My
question is, are there any tumor-specific characteristics that you entertain before you subject a patient for organ preservation?
I think now more and more we're going on actually the response to the chemoradiotherapy. I think at the moment most trials are choosing size as the entry criteria. So tumours really of less than 4 centimetres, particularly ones that are amenable to sort of TEMS resection. I think they're very when we see them now in the lower rectum, we're very tempted to put them into a trial into Star Trek, which we're lucky that we have that trial locally that we can put people into. So definitely size of the tumour and if it's resectable. But I think what's happening now is that with using TNT, we're starting to see more complete clinical responses in about 25%. So you've got a young man in front of you who's had you look and you cannot find this tumour. Are you going to go and do a TME and make him impotent, or are you going to just watch and wait? And you have to think about what would you do yourself. And so this is where it's becoming more difficult, because this is starting to happen, all these treatments are starting to happen off trials. And so there has to be very careful shared decision making and very clear documentation if that's what the patients want to consider. But I think it's really an evolving story. It's an exciting time. Thank you very much.
Pressed for time, and
Thank you.
we would move on. And next speaker is Professor Y.S. Lee, joining us from Catholic University of Korea, Seoul, St. Mary's Hospital. And he would be doing 2 talks. One would be on pelvic lymph node harvesting, and it would be followed by TME, TATME, robotic and laparoscopic surgery.
Hello everyone, I am Professor Yoon Seok Lee, a colorectal surgeon working at Seoul St. Mary's Hospital, the Catholic University of Korea. First of all, I'd like to give my special thanks to the organizing committee for inviting me. It is my great honor to participate in Sri Lanka Association of Colorectal Surgeons Conference. Today my topic is pelvic lymph node harvesting in rectal cancer, in other words, lateral pelvic lymph node dissection. Since the introduction of pre-op chemoradiation for locally advanced rectal cancer, the local recurrence rate was dramatically decreased from 30% to less than 10%. But there are still local recurrence. This is one study from Korea. They analyzed 366 patients who underwent pre-op chemoradiation followed by TME. The local recurrence rate was 7.9%, and among them, more than 80% of local recurrence was located in lateral pelvic recurrence. And this is the other study from Japan, the famous JCOC 0212 study. They reported that the local recurrence rate in TMA group was about 13%, and among the local recurrence, more than 50% of the local recurrence was the lateral pelvic side. There had been several controversies about the character of lateral pelvic lymph node. Some surgeons consider it local regional lymph node, and the other surgeons consider it as a systemic metastasis. Regarding treatment, some surgeons preferred the radical surgery, but the other preferred the chemoradiation therapy. In 2012, the Japanese group reported very interesting study. They compared the long-term oncological outcomes between local regional lymph node group with lateral pelvic lymph node metastasis. Interestingly, the patient who had the local regional lymph node metastasis and lateral pelvic lymph node metastasis showed very similar long-term oncological outcomes. The group with the lateral pelvic lymph node metastasis had better long-term oncological outcomes compared to stage 4 group. So based on their finding, the author concluded that lateral pelvic lymph nodes can be considered as a regional lymph node in lower rectal cancer. And this is another international collaborative study which was published in 2019. They evaluate the long-term oncological outcomes of the rectal cancer patient who underwent pre-op chemoradiation. Data from more than 1,000 patients with critical T3, T4 rectal cancer was evaluated. Among them, the 5-year local recurrence rate was 10%. And among the local recurrence, more than 50% of local recurrence were lateral local recurrence rates. And interestingly, the patient who had suspicious lateral pelvic lymph node metastasis had a significantly higher rate of lateral pelvic lymph node metastasis, and the patient who did not undergo the lateral pelvic lymph node dissection had more significantly higher rate of lateral pelvic lymph node metastasis. So after that, they concluded after the study, they conclude that neoadjuvant chemoradiation with the TME is not sufficient to prevent lateral local recurrence in enlarged lymph nodes. So based on those studies, Korean practice guideline recommended that the patient who had locally advanced rectal cancer, especially with a high risk for lateral pelvic lymph node metastasis, the practice guideline recommend neoadjuvant chemotherapy with followed by TME with the selective lateral pelvic lymph node dissection. At present, the lateral pelvic lymph node has 3 issues. The first one is what is high risk? The identification of high risk patients of lateral pelvic lymph node metastasis. Second is the indication of lateral pelvic lymph node dissection after neoadjuvant chemoradiation therapy. The last issue about lateral pelvic lymph node dissection is the surgical standardization of these complicated surgical procedures. What is high risk for rectal pelvic lymph node metastasis? Radiologically enlarged lymph node with a mixed signal intensity or irregular border of the nodal capsule could be considered as a high risk for rectal pelvic lymph node metastasis. But other than radiological morphology, the size is also very important to identify the risk, high risk for rectal pelvic lymph node metastasis. This is one study from Korea. They conclude that the patient with the lateral pelvic lymph nodes shoot axis diameter larger than 10 millimeter were at high risk of rectal pelvic lymph node metastasis. But the international collaborative study, which was published 2019, they reported that the lateral pelvic lymph node larger than 7 millimeter had a high risk for rectal pelvic lymph node metastasis. And recently, Japanese group reported that 8 millimeter is the optimal size criteria for rectal pelvic lymph node dissection after neoadjuvant chemoradiation therapy for rectal cancer. But other than lateral lymph node size, but the tumor distance from the inner verge is also very important. This is our data. We evaluated the 105 cases lateral pelvic lymph node dissection, which was performed from 2015 to 2020. And interestingly, when the tumor is located above the 5 centimeter inner verge, the initial lateral lymph node, which is larger than 8 millimeter, had a 100% sensitivity for rectal pelvic lymph node metastasis. But when the tumor is located 5 centimeters from the inner verge, the initial lateral lymph node larger than 6 millimeter has a 100% sensitivity for lateral lymph node metastasis. So in this study, we conclude that initial lateral lymph node size and the tumor heights were independent predictor of lateral lymph node metastasis. As I mentioned before, Korean practice guidelines recommend pre-op chemoradiation and selective lateral pelvic lymph node dissection for high-risk group. But there is some controversies about the responder. In case of poor responder, the selective lateral lymph node dissection is recommended. But what about the good responder? Actually, there are some controversies about the treatment strategy for the good responder after pre-op chemoradiation therapy. This is one study from Korea in 2014. They evaluate the 66 patients who underwent neoadjuvant chemoradiation followed by TME combined with lateral pelvic lymph node dissection. And in case of good responder after chemoradiation therapy, they could not found any lateral node metastasis. This is another study from Korea in 2016. They evaluate the patient of rectal cancer who underwent chemoradiation and TME with the selective lateral pelvic lymph node dissection. Group 1 is a TME only group because they do not have any suspicious lateral node. Group 2 is a good responder, and Group 3 is a poor responder. Interestingly, the Group 1 and Group 2 had a similar oncological outcomes compared to Group 3. Based on those findings, some surgeons insist that lateral pelvic lymph node dissection is not cannot guarantee a better oncological outcomes in good responder. But the other surgeon has a different opinion. This is also a study from Korea. They evaluate also oncological outcomes of the good responder and poor responder. And interestingly, even a good responder who omit lateral pelvic lymph node dissection had a significant higher rate lateral pelvic lymph node metastasis, recurrence. So they insist that lateral pelvic lymph node dissection cannot be omitted for patients with suspicious lateral pelvic lymph node metastasis on pre-treatment MRI, even in a good responder. So regarding treatment strategy between good responder is still controversial. Next, I'd like to talk about surgical approach of lateral pelvic lymph node dissection. Until now, several studies had reported the outcomes between laparoscopic and robotic lateral pelvic lymph node dissection. Until now, many studies reported very similar outcomes regarding perioperative outcomes, pathologic outcomes, and functional and oncological outcomes between two groups. This is our data. We compared the short-term oncological and pathological outcomes between laparoscopic and robotic lateral pelvic lymph node dissection. Both approaches had similar outcomes, but operation time was significantly longer in robotic lateral pelvic lymph node group, but number of harvested lateral pelvic lymph node was significantly higher in robotic groups. And lastly, I'd like to introduce my surgical steps of robotic lateral pelvic lymph node dissection. The gate lymph node in lateral pelvic lymph node group is located at the most deepest part around the Alcox canal or Pudendal canal. It is very important to remove the gate lymph node around Alcox canal or Pudendal canal during lateral pelvic lymph node dissection. This is basic anatomy of lateral pelvic lymph node. There are two fascias in there. The first one is uretero-hypogastric fascia, which contains ureter, hypogastric nerve, and pelvic splanchnic nerve. And the other fascia is vesico-hypogastric fascia, containing internal iliac vessels, superior and inferior vesical vessels, and internal pudendal vessels. And lateral pelvic lymph node divided in two groups. First one is obturator node group, and the other one is internal iliac node group. This is my surgical steps of lateral pelvic lymph node dissection. The step 1 is the section of uretero-hypogastric fascia. The step 2 is the section of the obturator space. Step 3 is the section of the vesico-hypogastric fascia. And step 4 is the section of internal iliac vessels. The first step is dissection of uretero-hypogastric fascia, and second step is dissection of medial part of external iliac vein. The third step is dissection of vesico-hypogastric fascia, and the last step is dissection of the distal part of internal iliac area. You can find the procedure in detail from the journal of our society, Annals of Coloproctology. I reported my surgical standardized step-by-step technique in this journal. Let me introduce my short surgical videos. First, I divide the uretero-hypogastric fascia. You can see this is ureter and this is uretero-hypogastric fascia containing ureter and hypogastric nerve and pelvic splanchnic nerve. I dissect as low as I can. As you can see, because this patient underwent pre-op chemo radiation, there's a lot of edema. And then divide the medial part of external iliac artery and vein. And if I continue dissection from down to the lower side, I can find internal obturator muscle like this. And also I divide as low as I can. During this dissection, careful traction and counter traction is very important. And then I divide the uretero-hypogastric fascia containing internal iliac vessels and superior and inferior vesical vessels. You can find this continue to dissect uretero-hypogastric fascia, vesical hypogastric fascia. And this is a obturator nerve and divide the obturator vessels around the obturator foramen here. And continue to dissect to the lower part. And then this is obturator nerve, carefully dissect around the obturator nerve. And this is obturator vessels. I ligate it at the proximal area. And continue to dissect. Carefully dissect around the obturator nerve, not to injure it. And this is a floor. This is a lumbosacral trunk. And carefully dissect at the floor part of lateral pelvic. You can see the ICG uptake lymph node. The reason of using ICG is not to detect the metastatic lymph node, but to check the completeness of the lateral pelvic lymph node. And continue to divide and ligate several veins. Then this is obturator node group, and then divide the internal iliac node group. The section along the internal iliac artery here, and internal iliac artery became internal pudendal artery around the Alcox canal. So lymph node dissection along the internal iliac artery is important. You can see here, this is internal iliac artery, became a pudendal artery around here. And check the ICG to check the completeness. And I saw several ICG uptake tissue in there. So this is the final view of the lateral pelvic lymph node dissection. So this is a ureteral hypoglossal fascia. This is a basicohypoglossal fascia. This is obturator nerve, and this is internal obturator muscle. This is external iliac vein. And you can see here, this is lumbosacral trunk. This is obturator nerve. This is internal iliac artery and superior inferior vesical artery. And here, this is Alcox canal when the internal iliac artery became pudendal artery. This is a final view of lateral pelvic lymph node dissection. Lastly, I'd like to invite all of you to our upcoming Lobot Conference. It's a 3-day international conference about rectal cancer, both including robotic and laparoscopic surgery at my hospital. I hope to see all of you at my hospital at this conference. Thank you for your kind attention.
We will continue the next talk.
My second topic is total mesorectal excision, laparoscopic versus robotic and transanal TME. Since the introduction of TME by Professor Hild, the TME for rectal cancer became gold standard for treatment of rectal cancer. TME is an essential surgical procedure to guarantee the oncological radicality in rectal cancer. Regarding surgical technique of TME, there are several surgical approaches: open TME, laparoscopic TME, and transanal TME and robotic TME. Since the introduction of laparoscopic TME and robotic TME, there had been so many studies which reported its oncological safety and surgical feasibility. So at this time, I don't like to review the many evidences of supporting the safety and oncological acceptability of laparoscopic and TME and robotic TME at this time. So at this time, I'd like to focus on surgical technique of laparoscopic TME and robotic TME and also TATM2. On the other hand, since the introduction of minimally invasive surgery for colorectal cancer, it became popular in colorectal field. Many studies already had reported oncological safety and long-term, short-term benefits of minimally invasive surgery for colorectal cancer. Actually, the penetration rate of laparoscopic surgery for colorectal cancer was about 80% in 2015 already in Korea, but it is technically very demanding procedure and has a steep learning curve. One of the solutions to overcome the learning curve in TME is making a good traction and effective counter traction and maintaining a good surgical view. Traditional triangular method, 2-point traction by assistant and 1-point counter traction with a simultaneous dissection by operator is recommended for surgical dissection. This triangular dissection method is also very useful in both laparoscopic and robotic TME2. During laparoscopic TME, it is important to make a continuous traction and counter traction. In this picture, two red arrows are traction by a assistant, and the blue arrow is counter-traction by a surgeon. Let me show you a short surgical video of laparoscopic TME. First, I start this section around sacral promontory and try to make a continuous traction and counter-traction to identify correct surgical plane. And the first part is identify inferior mesenteric artery. As you can see here, continuous making traction and counter-traction around inferior mesenteric
Hello, so
artery
this is from the technical
makes
team, Dr.
surgery
Ian.
less complicated. After
I hope you can hear
identify
me.
inferior mesenteric artery, apply
Yes,
clips
can you hear me?
and divide it
Yes, so your talk
for
will be the next
highlighting,
one. Will you
and
able
then
to
make
share
a
your screen? Then we
medial-lateral
can set the
dissection.
things up.
Yep.
And during the medial-lateral dissection, it is also very useful technique to apply traction and counter-traction method. My assistant make a traction, and I make a counter-traction like this. Try to make continuous traction and counter-traction is very essential part.
Yep, you got
And
that?
this is pelvic dissection.
Yes. One
After
second.
identifying correct surgical plane,
Get your visual as
my
well.
assistant make a continuous
Just again.
traction, and I make a counter
Right.
traction.
1 second. We are just
And this
mapping the
procedure
things. Give us 2 minutes.
Perfect.
is could be less complicated if surgeon can make continuous traction and counter traction method like this. And this is a posterior part of the rectum. Left posterior part. This is right posterior part.
All right. So you can keep the presentation shared.
And as you
That will
can
be
see
okay.
here,
If
in the
that
deep
is fine with you.
pelvis, sometimes it is difficult to make a traction and counter traction. At the time, a double traction method is useful for identifying correct surgical plane. This is the deep posterior part too. My left hand make a continuous traction.
So this
And
video will run
then this
about
is
16 minutes from now.
a peritoneal attachment of left side.
Dr. Ian?
Yes.
And this video will run for about 15
Divide the
minutes from,
peritoneal attachment.
to finish. So either you can keep your presentation shared, or you can, like, before 5 minutes time, again, you can share the presentation.
Okay, well, I'll just leave it
This
as
is
it is.
Yeah, so the
pelvic
video
side.
which is
This
playing
is
now
right
will run
side.
for another 15 minutes.
Perfect. So we're looking at
During pelvic dissection, it is also
57
minutes,
coming
important to
up.
make
15 minutes from now. Yes.
continuous traction and
Perfect.
counter traction.
And
My
Kishara will
assistant
introduce
make
me.
You can keep
traction
the presentation shared. That is okay.
Perfect. I'll
from
leave it
the
like
left
that.
side
Perfect.
of the
Thank you.
patient,
Thanks.
and I make a counter traction using my left hand. This is anterior side. This is a left side of pelvic dissection. This is anterior side again. This is a left deep posterior part. This is anterior part. This is the right side. And this is anterior side. I think this is the last step of the total mesorectal excision of this case. This is the deep posterior part. As you can see here, my left hand make continuously making a traction or sometimes counter traction. and then apply a Raynaud stapler. Then make anastomosis. Although laparoscopic TM is very popular at present, but there are still several challenges in performing a laparoscopic TME. The first is unstable or system-dependent camera surgical view, and second is difficult hand-eye coordination based on surgeon's experience. And third is poor ergonomics, and sometimes the surgeon can suffer from a tremor during a fine dissection, especially in a deep and narrow pelvis. Robotic system was introduced to overcome those challenges in laparoscopic rectangular surgery. Robotic surgery has stable 3D surgical view, and this surgical view is controlled by the surgeon. And it has end-wrist instrument with improved ergonomics, and also it had a function of tremor filtering. The lower rectal cancer surgery in Korea was first started in 2006, and along with the increasing in laparoscopic surgery also, but the robotic surgery is around 10% of the total rectal cancer surgery in Korea. But when you see the changes in composition of robotic procedure in Korea, the robotic anterior resection was the first to start in 2006, but the composition is slowly going down. And the simple low anterior section is also decreasing in robotic field. But regarding the ISL or ultra low anterior section, the composition in robotic procedure is increasing. That means many Korean surgeons apply robotic system in very low rectal cancer or very challenging lower lying rectal cancer surgery. Regarding traction and counter traction in robotic surgery, it is slightly different compared to laparoscopic traction and counter tractions because the robotic system has 3 arms, and among them the surgeon can use 2 robotic arms for traction or counter traction and 1 robotic arms for dissection. So surgeons who have to start the robotic surgery, the surgeon have to be familiar with different traction and counter traction method in robotic surgical system. As you can see in this picture, the surgeon have to use 1 robotic arms for different 2 direction of vectors to make a more effective traction and counter traction. It is slightly different compared to laparoscopic traction and counter traction surgical technique. This is a short video clips of robotic TAV, total mesorectal excision. The one robotic arm can make a traction of the upper rectum and try to identify avascular holy plane, and then the surgeon can use continuous dissection along with the avascular plane. As you can see in this video, the surgeon have to use 1 robotic arm to make a continuous and effective traction and contraction of the upper rectum to identify good surgical plane. This is posterior part first, and unlike the laparoscopic surgery, because the surgeon can use more stable 3D camera system in robotic surgery, as you can see in this video, the surgeon can enjoy very stable 3D robotic surgical view. I think that is one of the great advantages of using a robotic system in rectal cancer. This is right lateral side. As you can see, the 1 robotic arm make continuous traction and the other robotic arm make effective counter traction to identify a good surgical plane. As you can see here, this is the right posterior part. I try to make a continuous traction and counter traction, and using the first robotic arms, I can make effective traction around the uterus and vagina or cervix, and then the other robotic arms I try to make effective counter traction to identify a good surgical plane. And this is anterior part. continuous dissection, and this is the left side. This is left side colon, rectum, and this is left posterior side. Very stable 3D robotic system, robotic camera, and effective continuous traction and counter traction using 2 robotic arms make TME less complicated, even in a big, deep and narrow pelvis. And this is a left anterior side and posterior side again. You can see the camera is very stable. And this is anterior side again. Try to identify rectovaginal septum and divide the distal rectum from the posterior vaginal wall. And this is the left posterior side around the anorectal angle. You can see the beta muscle and puborectalis around here, and then apply robotic clip staplers. At this time, I used 2 robotic staplers to resect the distal rectum. And then this is completion of the robotic total mesorectal excision. Transanal TME is not popular. Actually, it's not popular in Korea, and personally, I have very little experience of transanal TME. Sometimes I use transanal TME technique in case of the intersphincter resection. In case of intersphincter resection, I sometimes use the TATME technique. First, I use a transanal and intersphincter dissection and dissect up to the 2 or 3 centimeter from the inner verge, and then I close the anus and apply a single port and start the TATME and entering into the peritoneal cavity. That is my personal technique of transanal TME. This is a very short video of intersphincter resection and starting from the down below. And first I close the anal canal to prevent the tumor cell spillage through the anal canal using a purse string suture, and then close the anus first. It is very important for the prevention of leak or the prevention of tumor spillage, and make a marking around the dented line. Actually, the marking area is based on the tumor location from the inner verge, and then inject the epinephrine saline in the intersphincteric area, and start the dissection from the down below. I enter the intersphincteric space from down below, resect the internal anal sphincter, and then enter into the internal intersphincteric space using monopolar electrosurgery. Usually I dissect up to 2 or 3 centimeters from the inner verge. It is enough. In Korean people usually anorectal angle, which is generated by puborectal, is located about 3 or 4 centimeters from the inner verge, and then check the dissection area and apply a single port. It's the preparation for transanal TME for in case of intersphincter resection, and apply a single port. And starting TATME. This is a short video, very short video of TATME in my case. I mentioned before, I have very little experience of TATME, so and in Korea the transanal TME is not popular. Only a few surgeons are doing a TATME. First, although actually I dissect about 3 or 4 centimeters from the inner verge already with under my direct vision, and then apply single port, and they're starting a TTM like this. And unlike the robotic or laparoscopic surgery, the make effective traction and counter traction is not easy. And you can see here the puborectalis muscle contraction, and try to identify correct surgical plane. Dissect carefully around the major rectum. Try to identify avascular plane. And this is the anterior side. Anterior side, surgeon have to pay great attention not to injure the urethra in male patient. In female, the surgeon have to pay great attention not to injure the posterior vaginal wall or rectal vaginal septum. And dissect very close to the posterior vagina or rectal vaginal septum, and continue to dissect. I'm almost approaching the peritoneal refraction side. This is a left lateral side. This is posterior, right posterior side. And if I continue to dissect the anterior side, I can enter the peritoneal cavity by making a window. This is a peritoneum, and if I continue to dissect, I can enter the abdominal cavity like this. That is my technique of TATME. Personally, I think the TATME is one of the good options in case of this situation. The tumor is very big and stuck in the pelvic cavity, so it is very hard to make a space. It is very hard to do a TME. So in such situation, I think the approach from down below, like TATME, is a very good option for the oncological resection. Lastly, I'd like to introduce one systemic review, most recent systemic review, which compared open and laparoscopic and robotic and transanal total mesorectal excision for rectal cancer. In this study, the rate of clear circumferential margin in rectal cancer surgery was similar between open TME and laparoscopic TME and robotic TME and transanal TME. And also completeness of TME, the open TME and laparoscopic and robotic and transanal TME showed no statistical difference between surgical approach. And also regarding perioperative clinical data or recovery, postoperative recovery parameters, surgical approach between open, laparoscopic, and robotic and TME showed no statistical differences. So they conclude that no difference was observed in oncological recovery parameters between open TME, laparoscopic TME, and robotic TME and TME. So regarding surgical approach of TME, no one can say which is best for TME. I think we have to find which way is the appropriate for the patient regarding perfect TME.
10 seconds
Thank
to finish,
you.
doctor. 10 seconds more.
Thank
Dr.
you
Ian,
for
10
your
seconds more.
kind attention. Thank you very much.
Thank you,
Will
Dr.
I be
Lee,
projecting on the screen?
for that informative talk. As Dr. Lee is not with us online, we'll move on to our penultimate talk, which is by Mr. Ian Lindsey from the Oxford University Hospitals in the UK. Mr. Lindsey is a colorectal surgeon and also has extensive experience in pelvic floor surgery, especially rectal prolapse surgery. Over to you, Mr. Lindsey.
Thank you, Kashara, and thank you very much for the kind invitation to present at this, what looks to be a really excellent new meeting. I know we're a little bit behind schedule, so I'm going to talk for about 20 minutes and leave about 10 minutes for any questions that might arise. This talk is quite a pivot from previous talks. We're going to be talking about functional disease, which is often poorly understood, poorly taught, and there may be more questions that you have than answers. And so it's important that we give some opportunity to clarify some issues at the end. I hope the differences between the Southern Asian and a Western European population and presentations and practice is not so great to make this talk less relevant than it could be. You can tell me whether that's the case or not. I'm going to make this talk quite pragmatic and maybe overly simple to try and simplify some concepts, because the request was to really talk about obstructive defecation and clinical decision making. When you open a textbook of colorectal surgery, if you had to find a chapter on functional disease and in particular obstructive defecation, you'll be met with a list of causes, as you'll see on the screen there. This kind of overly inclusive, extensive list is academically maybe necessary, but clinically completely unhelpful, and therefore, in overly simplifying the situation, we can perhaps help you clarify your decision making. So I think you have to remember that obstructive defecation is not a diagnosis; it's a syndrome. It's a functional syndrome with considerable overlap with fecal incontinence, with an underlying spectrum of causes. At one end, we have functional, if you like, medical causes, which tend to be treated with conservative measures. At the other end of the spectrum, what we're most interested in, or maybe called upon to intervene more commonly, is structural causes such as prolapse or rectocele, and sometimes there's a blend between the two. So we're really looking to identify patients with the syndrome, and that can be done clinically. If we convince ourselves, and supplemented by tests as well that correlate with that syndrome, but predominantly clinical to detect it. If there is obstructive defecation identified, we need to go under the hood and determine what the underlying particular cause is, and that is really best done by tests, but also suggested with some support by clinical evaluation. And then when we're tossing up whether to treat patients conservatively or surgically, it very much depends on a whole host of factors, but in particular the causes we've said before, structural versus functional, but also the impact or severity of the condition and the impact on the patient's quality of life. So I think if we can answer these three questions conceptually in our heads as we're seeing patients or working them up, we can just help crystallize some thoughts on decision making. This is a sort of summary slide of my current latest philosophy, I guess, on management of obstructive defecation. This hasn't always been the case, and when Kishara was in Oxford, things might have been a little bit different, but I think what I try and do is look for three groups of patients. Firstly, clinically and with tests, I look for patients with anismus. This contributes maybe about 5% of patients, about 1 in 20, but it's a group of patients with effectively a spastic pelvic floor or puerectalis who can be treated very simply, as we'll talk about, with some Botox or conservative treatment otherwise, but we would favour Botox. I try and pick out patients with an isolated rectocele because I think they don't necessarily do so well with conservative treatment. They have a very discrete anatomical problem and can be treated with a relatively low impact operation without prosthetic. And then I really more and more are making an effort to apply all the conservative measures for the rest of the patients. And if by chance someone pops out of that process unimproved or deteriorating, and gets investigated and turns out to have an internal prolapse or intussusception, then as long as they haven't got adverse predictors of a less good outcome, and we can talk about that, and as long as we manage expectations with carefully and clearly, then they may be candidates for intussusception surgery, but on a pretty selected basis these days, and we'll talk about why that is the case. Just to make people aware, I don't know how many functional surgeons are in the audience, but you know, I didn't really, as a surgical trainee, didn't really get taught much about obstructive defecation. It was really left to my curiosity and clinical practice as a consultant to be self-taught on it. And these are some of the symptoms that can be hidden away in your general clinics in patients who maybe present with a potential cancer for exclusion that come through a rapid pathway, maybe with a change of bowel habit. With closer questioning, you may uncover some of these more particular symptoms. Incomplete evacuation, spending long periods of time in the loo, frequent visits back to the loo for incomplete evacuation, digitation either rectally or vaginally. It's a particularly functional indicator, and with abdominal and sometimes pelvic pain associated with it. This is a chart showing 7 components of the Wexner constipation score, which is probably the most commonly used score, with a ranking of the predominance of those symptoms in patients presenting generally to a clinic randomly, but also the effect of rectopexy, ventral rectopexy surgery on those symptoms ranked by frequency in the post-op and pre-op state, but also the different, and you can see the kind of symptoms that predominate. It's interesting that the striking feature here is that these symptoms tend to go hand in hand. So they improve hand in hand, they appear hand in hand as very much a web of symptoms to constitute a syndrome. And maybe most strikingly is the improvement in stool frequency, or with post-operatively, but also stool infrequency, which we would tend to associate with slow transit constipation, being not an uncommon feature of obstructive defecation. So I think that's a key learning point, even though you might have a patient with obstructive defecation who anticipate frequent attempts at stool, but patients can actually present with stool infrequency not uncommonly. It's important to set the right environment. Patients often won't trust you with their symptoms. They've been hiding these embarrassing symptoms for many years, and sometimes they'll volunteer them to you for the first time, in front of their husbands or partner, having hidden these symptoms or kept them to themselves for some time. So setting the right tone and environment is very, very important to flush out these symptoms. And then various various measures clinically to detect essentially a weak pelvic floor with prolapse in the standing or lying position, as demonstrated there. I think it's important to try and objectively measure and grade people's symptoms. You can use any one of these. The PAC SIM score is really the only one that has been validated, and it comes with a quality of life measure as well, but you are free to use any of these measures. This is the quality of life measure that bolts on, and it's an excellent way to document the extent of patients' symptoms and improvement with conservative or surgical intervention. I think it's important that we rule out organic pathology. Once a patient is in a functional workup, it's very hard to determine a change in patient's bowel habit purely from a non-functional perspective. So it's important to clear the decks early, and then our sort of standard pelvic workup would be barium proctography and some physiology and ultrasound. Transit study, we think, is less and less important these days, and one can choose to work patients up at the time of clinical assessment, which is a more expensive but inclusive approach, which will pick up things like occult, undeclared external prolapse, or after failed conservative treatment, which is perhaps more cost effective, but will lead to maybe under recognition of some external prolapse that will clearly not respond to conservative measures. And then we really integrate the practice of clinical practice, clinical assessment, determination of tests to test structure and function and their interpretation, and integrate that with a conservative treatment with a team of usually pelvic floor nurses and physiotherapists who can roll out some of the extensive non-operative measures that we have at our disposal, and we can list them shortly. We're really going to focus on these three conditions: anismus, rectocele, intussusception in broad conceptual terms, recognizing that we'll throw up other conditions like external prolapse that the patient was unaware of associated with obstructive defecation, a rectal dysmotility, which is a sort of poorly described functional disorder, perhaps related to nerve injury or other conditions. Slow transit constipation, which we've talked about, and constipation predominant IBS, they're the main sort of candidates. Generally speaking, we test quite extensively, largely because we don't really know what we don't know. We do the same thing in rectal cancer, for example. We do a lot of MRI scanning on patients who perhaps in hindsight didn't need such extensive local staging. That might have been the current view 20 years ago. These days we accept it as standard. I think the more information one knows, the better can be the decision-making, case selection. And if we don't do the test, we won't know how to choose the patients on the basis of the test results. So I think better understanding, more information. Interpretation of tests is a skill from looking at a lot of proctograms. I think recognizing dispositions of vertical and horizontal rectums, as we'll talk about, can aid in prognostication, recognition of rectocele, and recognition of intracele. This is really all part of a sort of practical skills that one learns from just steady digestion of many proctograms over a period of time. Briefly, colonic inertia. This is a condition I don't really fully understand. I mean, the textbooks are pretty clear that slow transit equals infrequent stool and at times total colectomy, but we do fewer and fewer colectomies these days. These are some Oxford data looking at all patients with chronic constipation, and we can see that a very small proportion of patients have pure colonic inertia, about 5% of patients. These patients more often had stool infrequency, but the stool infrequency wasn't confined to them. And we concluded that colonic inertia in an isolated manner was a pretty uncommon cause of chronic constipation overall. And largely treated medically in our hands. The first group really want to talk about is anismus, because it's a group of patients that can be detected very early on clinically with a rectal examination, asking a patient to bear down, and if there's any involuntary contraction of the sphincter and puborectalis, despite instructions to relax and bear down, then the clinical suggestion of anismus can be raised. There's a whole lot of complex diagnostic criteria which are highly technical and highly impractical, and we try and keep it fairly simple, and our diagnosis of anismus is a pragmatic clinical one, i.e. if you respond to a dose and the appropriate dose of botulinum toxin injected into the puborectalis and external sphincter in a typical manner, then that is a de facto diagnosis of anismus. If you look at the literature, there's a pretty variable response to anismus, from response in the 30s up to 100%. So clearly something is going on in some patients. We noticed in our practice about a 40% response rate and a typical disappearance of that response rate after the 3 months or so after the first treatment, with a almost 100% second response rate with a second injection that was sustained over time. So if you like, the first injection can be considered the diagnostic, the second the therapeutic response with a prolonged response. And when we looked at this group of patients from the original 56 who hadn't responded, we examined them under anaesthetic. We found a pretty high incidence of substantial rectal prolapse with a revised, much higher Botox response rate. In other words, our diagnostic criteria were proctographic and over-included a large chunk of patients who had effectively a pseudo-anismus, but underlying that, they really had a prolapse. And when that group was excluded, patients responded very well to Botox. It can be given simply in clinic without any local anaesthetic, with a pretty substantial dose of Dysport or Botox, usually 1 ampule. Many of you will see and treat rectoceles. I don't want to go into huge technical detail, but I think it's important to recognise this as another group that can be picked off and treated quite simply. It can be identified as patients with very local obstructive defecation symptoms, confined really to the perineum, with trapping of stool in a bulge, digitation vaginally or rectally in that bulge, and not a lot of abdominal symptoms, mainly perineal symptoms. There's not a lot of evidence that conservative treatment or irrigation works well in this group in particular, and given the relative ease of surgical intervention, then one can make a case for not putting a patient necessarily through a prolonged period of conservative treatment that one might for, say, a patient who is facing an otherwise mesh intervention. So I think the threshold for surgery in this group is a little lower. It's important to document the structural problems on proctography, and also if we're offering a transanal approach, really an anterior Delorme's type transanal approach, sometimes known as a block or a Sales approach, that we should make sure the patient's sphincter is not particularly weak, because the transanal approach may exacerbate this and induce some incontinence. That can be mitigated with the use of an anal or pudendal block to paralyze the sphincter during surgery. But an alternative approach often used in more elderly patients might be a transvaginal approach, in the hands of a gynecologist, which gives effectively the same outcome. So younger patients transanal, older patients perhaps a gynecological transvaginal approach. Transperineal approach is probably used less and less these days because of the risk of entry into the vagina or the rectum. I don't want to labour the extensive tools at our disposal for conservative treatment. Very, very important that the patients work through these in a consistent manner. Patients are offered conservative treatment up front, as one of the indications for surgery is failure of such conservative treatment. And we can talk about laxatives, prokinetics, which are often given by gastroenterologists, suppositories and enemas, and some of the more invasive and expensive measures that the pelvic floor nurses or physiotherapists might be involved in, including rectal irrigation, colonic irrigation, with a stoma, if you like, not really a conservative treatment, but a sort of stoma as sort of an end point to that. Rectal irrigation is effective and can be popular in some patients, maybe not popular is maybe not the word, but useful, effective. But it does come with a cost, which is getting on for the annual cost of a stoma. Particularly the new Q4 device with a little cone for rectal irrigation, patients can find that particularly useful. And so it's useful for patients with functional neurological problems rather than structural problems, and patients who have perhaps failed surgery or are unfit for surgery. Lastly, I just want to touch upon maybe a more controversial topic. What's the role of intussusception surgery? I think it's pretty standard these days for external prolapse. There have been some mesh issues, but I think with the use of biological mesh, these risks can be mitigated. And functionally, there's certainly good evidence that where posterior rectopexy for external prolapse can slow down hindgut motility, ventral surgery can actually promote or enhance hindgut motility. So there are good functional reasons for considering ventral surgery, not just for external prolapse, but perhaps for patients with high-grade internal prolapse that looks very much like or borders on frank external prolapse, so grade 4 intussusception. We've been practicing this for some years in Oxford. We kicked off our program in the mid-2000s with a very carefully conducted audit of patients who were carefully selected and audited and compared with our relatively recent practice of ventral surgery for external prolapse. And we found very, very similar when patients were selected on that basis as resembling external prolapse patients, very similar functional results, similar improvements in constipation scores in grade 4 prolapse, as well as external prolapse, with improvement in quality of life. But at what risk, some skeptics might ask, and this is a collective study looking at mesh in several centres around the world in some, at that time, fairly high volume centres. Many more people will have experience of this now. And overall across this group, and probably related to the use of non-dissolving Ethibond sutures in Prolene mesh, there was an incidence of 2% minor erosions that could be treated locally conservatively without mesh explantation, and about 2 in 1,000 risk of major fistulas, mesh infection that required explantation, and there was a lower risk in biological meshes. So there is a risk, there is a price to be paid, and that always needs to be balanced against benefits of surgery. So just to finish off and summarise, this is really how I think about obstructive defecation. I try and identify patients with both anismus and rectocele who can, really constitute two quite discrete groups who can represent fairly easy wins. I then try and subject other patients to a battery of conservative measures. We tend to investigate after failed conservative treatment these days rather than upfront for financial reasons, and also we have generated predictors from our previous practice that we can now use. These include trying to avoid surgery in younger patients, patients with pelvic pain, patients with Ehlers-Danlos connective tissue disorders who have a high incidence of pain and recurrence and reoperation. grade 3 patients do less well functionally than grade 4 patients. So I think we're really looking at patients who are on the cusp of external prolapse structurally. And patients with a horizontal rather than a vertical rectum seem to biomechanically do less well than patients with a more vertical rectum. And this can be identified on proctography. And then expectation management, recognizing that any improvement in quality of life and constipation needs to be offset against the risks as detailed below, the risks of chronic pain, the risks of ongoing bowel dysfunction, either persistent or recurrent, and the small risk of rectal erosions, which can be, I think, as I said, mitigated with the use of prosthetic meshes. Thank you very much.
Thank you, Mr. Lindsey. That was an excellent talk on a very difficult topic. I'd like to open the floor for any questions. Could I ask you, Mr. Lindsey, now if patients with features of obstructed defecation who show features of an internal prolapse, no external prolapse, how would you approach such a patient?
So I presume I've seen this patient in clinic, and they've had a proctogram, and we can identify a grade 4 prolapse. This will have been after a trial of conservative treatment, and this patient generally gets punted back by our pelvic floor nurses with a request for proctography and physiology, and we'll then see them in the clinic. And then we're really, looking at balancing of risks, finding out, how bad the patient's symptoms are, generating a constipation score, looking at the effect of their symptoms on a quality of life, what an effect the conservative treatment had on them, how persistent they were in and thorough they were in using that, how badly they got on with irrigation or couldn't cope with irrigation. We sometimes talk about a stoma as a way of triangulating things for them. And then if the proctography looks favourable and the patient looks suitable and there's no major psychological issues, we'll take that patient to MDT and propose a ventral rectopexy with biological mesh. We don't do large numbers of these, using that algorithm. We're probably getting on for the order of 10 to 12 a year. There'll be some centres that will, a lot of these patients will have an associated rectocele, and they'll offer them a rectocele repair first. This is the Auckland approach. Auckland, New Zealand have got a very prominent pelvic floor unit. They will offer them upfront a rectocele repair to try and take out as many of the patient's symptoms just with a simple local repair. And anyone who fails will be then candidate for a mesh rectopexy. So that way we're really not over-treating patients with mesh. I think that's quite a nice approach if to use as a way of mitigating that risk of mesh, and we do that on occasion.
Okay, and in patients with global compartment prolapse, that is patients who've probably got a connective tissue disease, anterior, middle and posterior compartment prolapse leading to perhaps obstructive defecation as a component of many other symptoms, how would you approach that patient?
This is a difficult one because it very much depends on whether they've got an underlying connective tissue disorder. I mean, if it's a young nulliparous patient and the problem is global across the pelvic floor, then bitter experience has shown that even though these patients' symptoms, are particularly bad, they do, in the long run, do particularly poorly with surgery. with a high incidence of recurrence. Their incidence of recurrence is double that of patients without connective tissue disorders. Their incidence of chronic pelvic pain, probably related to the elasticity and recurrence above the mesh, is substantial, and their reoperation rate substantial. So it's difficult counselling these patients. They may be better off with a limited posterior rectopexy without mesh as a temporary measure, but the group with failed connective tissue really almost need to be seen in the palliative setting despite their young age. It's really not the area for heroic measures, if that makes sense. I think there's another group of patients who've got just an associated middle compartment prolapse, and that strategy in that group of patients needs to be resolved with urogynecologists. It may be that one of you goes first, and that might lead to an improvement or otherwise of the associated symptoms. In our experience, unless they've got two clear prolapses that are both indications for surgery, double surgery is often too much for a single patient. The convenience of a single anaesthetic might seem reasonable, but in our experience, two surgeries at once is almost too much for the patients with a lot of slow recovery afterwards. So we tend to not do multi-surgeon operating on these patients these days, certainly less than we used to.
Okay, thank you very much, Mr. Lindsey. It was a very enlightening talk, and thank you for your time.
Thank you very much.
If you could call Ms. Claire McNaught on stage for, we've got a token of appreciation for your participation today.
Thank you for that entertaining panel discussion. Next, I would like to invite upon stage Professor Neil Mortensen, Professor in Surgery, University of Oxford, to talk about future in colorectal surgery.
You'll be very pleased to hear that I'm not going to be very long. And in one way, the future of colorectal surgery is already here. I think this symposium has brilliantly illustrated that this is no longer a very, very simple subject, but is much more complicated than everybody had ever previously thought. Now, first of all, many congratulations on forming the Sri Lankan Association of Colorectal Surgeons, and I'm delighted to be speaking at it. Colorectal surgery has come of age. We talk about Cinderella being left behind. It used to be called a Cinderella subject. It isn't anymore. Huge changes in 25 years. And I have demitted only in 2019 as the editor of Colorectal Disease, the journal, and even in those 3 or 4 years has been massive change. Super specialization, as you can see, is absolutely key. Even within the subject areas of colorectal surgery, nobody can, if you like, be good at all of the various subspecialties. I alluded when I first spoke on Thursday morning about this report. I won't go into detail about it, but I'll just briefly summarize the main findings of the way in which our report at the Royal College of Surgeons of England looked at what might happen. And you've heard again over today that this is exactly what is happening. Genomics for personalizing surgery, particularly in cancer. You've seen examples of robotics. You've seen how important it is for people to work in teams. You've seen 3D printing being used to carefully dissect in CME surgery. And I'm just going to mention 2 or 3 things to summarize where I think colorectal surgery might go in the next little while. I'm first of all just going to mention, in a way, the elephant in the room, which is that we still don't do brilliantly at an emergency colorectal surgery. Lots of patients come in with emergencies, and they tend to be dealt with by not necessarily the optimal team. This National Emergency Laparotomy Audit has done much to concentrate minds and improve outcomes. I'm just going to show you a few figures from that. You can see now that hospital mortality for all comers is around 9%. It's stayed around there or come down a little bit since year 7 and year 6 of the audit. Now it's 8th year. Median time to antibiotics in those suspected with sepsis is 3 hours, probably still too long. Presence of both an anesthetic consultant and a surgical consultant during surgery, now up to 90%. In many places, there's still much room for improvement. Median length of stay of these patients, 29 days. These are complex patients, highly at risk, and they need the best we can give them. And therefore, I think that's one of the areas where colorectal surgery needs to improve. Second area I'm going to talk about is obviously colorectal cancer. You've heard about rectal cancer and colon cancer today. Clearly, screening will result in earlier diagnosis. Surgery will therefore be able to be carried out at an earlier stage. We've talked about organ preservation. We've talked about the effectiveness of adjuvant, neoadjuvant chemoradiotherapy, and you've seen lots of examples of robotics being used. You've just had a presentation on functional bowel disease, and you thought it was simple, and by goodness, it isn't. We clearly need lots more research and a better understanding of the physiology of how the pelvic floor and the colon works to allow for drug development and safer implants, and there will be mandatory registries for these patients in due course too. In IBD, colitis and Crohn's disease, again, you heard a presentation on colitis earlier. Joint management with our physician colleagues is essential. The whole team takes responsibility for outcomes. Timing of surgery is really, really important. Joint decision making, obviously more minimal, and robotic surgery, monoclonal antibodies. I'll just get you to consider a moment what's happened in rheumatoid arthritis. Inflammatory disease treated with monoclonal antibodies, and you can see here my colleagues in Oxford do much less rheumatoid arthritis surgery than they used to because of the effects of biologics, and this too could have an effect on inflammatory bowel disease. I mentioned that we put a robot in the entrance hall of the College of Surgeons in London in September, and this is the big change, isn't it? Urology and colorectal surgery seem to be the areas where there is the most obvious rapid application of developing robotic platforms. And I showed this slide yesterday around the way in which the robotic companies themselves are doing the teaching and training. We probably need to take control of that and do some of that ourselves. And we can use the robotic platforms for proficiency-based progress in our surgical credentialing for the use of these complex techniques. We've mentioned AI and the way in which AI may actually inform surgery. The robots are going to be miniaturized. This robot is going to be on the International Space Station. Robots are going to be using augmented intelligence. These are some of the things that will be happening with robotics: miniaturization, tactile sensing, haptic feedback, eye tracking, image recognition, and perhaps autonomous robots eventually. Will it all really happen? We live in an unpredictable world, of course, and there is much discussion about a fair distribution of care. Much depends on the funding that becomes available for these expensive pieces of equipment. Much will depend on our leadership, on the way in which we safely introduce these new technologies. Patient safety is really important. It's been an issue in ventral mesh rectopexy. It's certainly been an issue in the too rapid introduction of robotic surgery in some institutions, and it's certainly been an issue around the balance between surgery and inflammatory bowel disease, between medical treatment and surgery and inflammatory bowel disease. We have to keep that at the forefront. I've had a brilliant and very, very rewarding career in colorectal surgery. Clearly today has shown that that's still going to carry on, and there's much excitement to be seen in the future of this, what was once a Cinderella subject, but no more. Thank you very much.
Thank you, sir, for that valuable insight into our field. I would like to call upon Professor Pramod Chandrasinghe, Consultant Colorectal Surgeon, Faculty of Medicine, University of California, to deliver the vote of thanks.
Thank you, ladies and gentlemen. I think as the inaugural conference organized by the Sri Lankan Association of Colorectal Surgeons, it is fair to say that we had an excellent lineup of talks discussing some of the hottest topics in colorectal surgery. I would like to thank each and every one of our speakers who took time out of their busy schedule to join us here today for the Sri Lankan Surgical Congress. Professor Neil Mortensen, we couldn't have asked for a better person to deliver the keynote. Thank you, sir, for your time. I should make a note of thanks to our sponsors who made all of this possible. Without your support, we wouldn't have made this a success. Last but not least, I would like to invite Dr. Vasantha Wijanayake, the President of the Sri Lankan Association of Colorectal Surgeons, to present a token of appreciation to Professor Neil Mortensen. The presentation will be done by Professor Arjuna Lubihari. Thank you, ladies and gentlemen, and wish you all a good evening.